Hi, this is Neha Sarkar, an epidemiologist working in the New York City Department of Health. The presentation entitled Expedited Partner Therapy Acceptance in a School Screening Program in New York City between 2014 and 2019. I'd like to acknowledge the work of my co-authors at the New York City Department of Health, Kira Smith-Moore, Joyce Wilson, and Sarah McKenna. The New York City Department of Health and Mental Hygiene's Bureau of Sexually Transmitted Infections provides STI education and urine-based chlamydia and gonorrhea screening at public high schools. The program has been in operation for more than a decade as a supplement to traditional sexual health education curriculum and sexual health services offered at school-based health centers. Students who test positive for chlamydia on one of our school screening days are offered free treatment. We provide treatment to them at their school by a nurse practitioner or MD, or we arrange for them to receive treatment at one of our sexual health clinics. Sometimes the students receive treatment at the school-based health center or with a private provider. Students who receive treatment from us are interviewed to identify sex partners and offered expedited partner therapy. The objectives of the paper were to identify the proportion of students who tested positive for chlamydia and accepted EPT, and to understand why students refused EPT. This slide shows the method we used for this research. We analyzed EPT acceptance among students tested between July 2014 and June 2019 and reviewed reported reasons for EPT refusal. Of note, we only know about EPT acceptance among students who are interviewed and treated by our staff. We do not know about EPT acceptance among students who are treated elsewhere. Male students who report sex with men and or those with gonorrhea co-infection are not eligible for EPT. When eligible students refuse EPT, staff document their reasons. Table 1 orients you to our program by showing the summary findings by chlamydia or gonorrhea positivity by year between July 2014 and June 2019. During these 5 school years, we educated over 29,000 students from 211 schools. Of all of these students who received STI education from our staff, 39% participated in testing. Among the students who had participated in testing, 3.9% were infected with chlamydia or gonorrhea or both. Chlamydia infection without gonorrhea co-infection was found among 424 students. That is, 3.7% of the students who participated in testing. Figure 1 presents the EPT cascade among students diagnosed with chlamydia between July 2014 and June 2019. Chlamydia infection without concurrent gonorrhea infection was found among 424 students, and 89% received documented treatment. Of 376 students, 75% were interviewed and assessed for EPT eligibility. 97% students were eligible. Of 272 eligible students, 114 or 42% accepted EPT. Figure 2 shows the reasons for EPT refusal among 158 students. 48% students who refused EPT reported that they were no longer with their partner. A further 14% students reported that their partner had already been treated, and the same proportion preferred the medicine be delivered by a clinician. The rest, 13%, declined EPT for other reasons. EPT refusal reason was missing for 11% students. Table 2 shows EPT eligibility by age. First column shows the age groups. Second column shows the number of students EPT offered. Third column shows the proportion of students accepted EPT by age groups. Fourth and fifth columns show number of EPT packets distributed. We did not see a clear pattern in EPT acceptance by age. Most students across all age groups accepted one EPT packet instead of two. Table 3 shows EPT eligibility by sex. We also did not observe a clear pattern in EPT acceptance by sex. We observed a trend of more male than female students accepting multiple EPT packs, but the total number was still low. Table 4 shows EPT eligibility by race ethnicity. We did not observe a clear pattern in EPT acceptance by race ethnicity. Table 5 shows EPT eligibility by school year. No remarkable variation was observed in EPT acceptance during last 5 school years. This slide shows the limitations of the research. We only interviewed students who received treatment with our staff or in our clinics. We did not receive information about EPT acceptance among students treated elsewhere, such as with a private provider. In conclusion, less than half of EPT eligible students accepted EPT, suggesting missed opportunities to prevent reinfection. The most common reason for declining EPT was that the students were no longer with their partner. This suggests to us that program improvement efforts should concentrate on counseling messaging around the importance of treating partners. Thank you. Any questions? Feel free to ask. You can contact me over phone, fax, or email. Thanks again.
Hello, my name is Patty Kissinger from Tulane University in New Orleans, Louisiana. I'm going to speak to you today about a study we did examining anal and oral sexual behaviors among young Black or African American men who have vaginal sex. I have no disclosures at this time. I want to talk a little bit about the background. Screening for chlamydia and gonorrhea in the genitals alone may miss extragenital infections. And we know that extragenital infections may serve as a reservoir for future genital infections, so there can be self-inoculation. Treatment of extragenital infections may be different than the treatments for genital infections. For example, in the context of chlamydia, genital infection, you can give a single dose of azithromycin, but in an oral infection, you need multi-doses of doxycycline and other medications. There is very little information on extragenital sexual behaviors in this particular group of young African-American men. There's much more information among men who have sex with men, but this population of young African-American men who have sex with women, they have a high rate of chlamydia. So we want to look at this particular population. The purpose of the study was to describe oral and anal sexual behavior, barrier usage during those sexual acts, and the chlamydia and gonorrhea positivity rates for this population. We examined young Black and African-American men who ever had vaginal sex. They were screened through our Check It program, which is a community-based screening program in New Orleans. We took urine specimens and examined them with nucleic acid testing for chlamydia and gonorrhea. And the study went on between August 14th of 2019 and February 29th of 2020. We used audio computer-assisted self-interviews to reduce the potential for social desirability, and we collected information on demographics, sexual behavior, and a battery of many other questions. We used chi-square and Fisher's exact tests to assess differences in these behaviors by their chlamydia and gonorrhea positivity rate. A little bit about the cohort. We had 397 men enrolled. They described information on 657 female partnerships. The median number of lifetime female partners was 5, with a wide range of 1 to 90. The percentage of men who had sex who also had sex with men, so these are men that had sex with women and had sex with men, was 2.3%. The mean age of the men in the study was 19.8. The mean age at sexual debut was 15.1. And very few of the men had symptoms, only 5.3%, which is not, which is unremarkable because this is a community-based screening, so we did not expect them to be symptomatic. What was remarkable is the very high rate of chlamydia and gonorrhea. Either chlamydia or gonorrhea, 13.5%, but it was largely driven by the chlamydia rate, which among those men was 12.5%. There was 1.8% of the men who had gonorrhea only, and less than 1% had co-infections of chlamydia and gonorrhea. This pie chart describes sexual behaviors. These are mutually exclusive. You'll note that 7.5% had no sexual partners, and that was because we relaxed the inclusion that you had to have had sexual partner in the last 60 days about midway through the study. So these are all behaviors reported in the last 60 days. 7% had no sexual partners in the last 60 days. 42% engaged in vaginal sex only. 46% engaged in vaginal and oral sex. And 5% engaged in vaginal, anal, and oral sex. So if you add the 5 plus 46, you get 51%. So 51% of the population engaged in some kind of extragenital sex. When we were examining barrier usage by those sexual behaviors, 92.7% engaged in vaginal sex, and 31.7% of those used a barrier, so a condom. 43.4% received oral sex from a partner, and 29.1% used some kind of barrier during that sex. 31.7% gave oral sex to a partner, and 9.7% of those used a barrier. 5.5% engaged in anal sex, and we did not collect information on barrier usage during anal sex, or adding that, but we didn't have that at the time. There was a small population of men who also had sex with men, and 9 of those men, so that constitutes 23% of the cohort. 4 of those men engaged only in anal sex. 5 engaged in performed oral sex, and 5 received oral sex, and neither of those persons those men engaging in oral sex used a barrier method. When examining condom usage and chlamydia rates for vaginal sex, so condom usage during vaginal sex, when you look at the difference between the two, you see no difference, that both of them are about 14% for chlamydia or gonorrhea rate if they used condoms all the time, or if they didn't use, they had a condomless sex act. And that was not statistically different, so no different. This suggests that there might be some other source of this infection. It is possible that they could have been prevaricating a bit on their condom usage, but the fact that we used a computer-assisted survey likely diminished the social desirability. So we really think this may have been driven by extragenital infections and self-inoculation. If you look at the 2 largest categories, which was vaginal only and vaginal and oral, by chlamydia rates, by condom usage, among those who had vaginal sex, you can see that those who had condomless sex were obviously far more likely to have an infection, but there is still 10% of those men who said that they used condoms all the time still had an infection. That was not statistically significant, but potentially a borderline. Among those who had vaginal and oral sex, those who used condoms all the time had a higher rate of infection than those who did not use condoms all of the time. And that was approaching statistical significance. So this again suggests that there is a reservoir, the potential reservoir of infection that could be attributed to extragenital sexual behavior. There are limitations to our study, of course. Findings are only generalizable to young African-American or Black men living in New Orleans or living in the South who had vaginal sex. So we did not ask people who did not have vaginal sex. So there's possibly young men who are just having oral sex or just having anal sex, and we did not include those people in the study. We also do not know about condom usage during anal sex. That was a oversight, and we're adding that in for the future. Our conclusions are unprotected oral sex with female partners, both giving and receiving, was common. And the prevalence of chlamydia and gonorrhea was high in this population. The role of extragenital testing, particularly oral testing, to reduce sexually transmitted infections should be considered in this population. I want to acknowledge my co-authors. I also want to thank very much the participants and our community partners who helped us to get these men screened and gain access to this population. And also I want to thank National Institute of Health and ICHD who gave us the funding to do this study. And of course, our wonderful study staff who work tirelessly with this population, and I want to thank them for all their efforts. And thank you very much for your attention.
Hi, I'm glad to have this opportunity to present findings related to parent engagement and confidentiality in publicly funded health centers. As the title of our presentation suggests, we consider whether these principles are at odds or whether parent engagement in health services presents an opportunity for advancing adolescent STD prevention. Before diving in, I want to acknowledge my co-authors from the Division of Reproductive Health, as well as the grantees and survey respondents from the Teens Access and Quality Initiative, who provided the data for this analysis. When it comes to adolescent healthcare, and particularly sexual and reproductive healthcare, confidentiality is paramount. Practice guidelines from professional medical organizations underscore confidentiality as a cornerstone of care, in part because confidentiality concerns, such as around disclosure of sexual activity to parents, are a known barrier to adolescent healthcare seeking. Clinic and provider level confidentiality practices include, but are not limited to, recognizing state laws that give minors the rights to access STI testing and contraceptive services without parental permission or notification, providing time alone with adolescent patients in which the parent is not in the exam room, and implementing billing procedures that minimize disclosure of services via explanation of benefits. As these examples illustrate, confidentiality practices help to ensure that adolescents can access sexual and reproductive health care without the engagement of parents. However, it is well documented that parental engagement in an adolescent's life can have a positive influence on their sexual behavior. In particular, parental monitoring and parent-adolescent communication are protective factors associated with reductions in adolescent sexual risk, such as delayed sexual initiation and improved condom use. Less is known about the benefits of parent engagement in relation to health services specifically, likely because of the emphasis on confidentiality. In recent years, though, there has been growing attention to what is termed a triadic approach to adolescent healthcare that considers parents as partners of both adolescents and providers, as illustrated on this slide. Despite this interest in parent engagement in health services from a conceptual perspective, there is limited empirical data on the topic to date, especially in context with confidentiality practices. That's where the Teens Access and Quality Initiative, or TAC, comes in. This quality improvement project, funded by CDC in 2015 and wrapping up this fall, aims to improve the quality of adolescent sexual and reproductive health services at publicly funded health centers and increase access to these services via referrals from youth-serving organizations. To achieve these goals, 3 NGOs were funded to provide technical assistance to health center and youth-serving partners. The grantees included the Georgia Primary Care Association, working in Chatham County, which includes Savannah, Georgia, Shift North Carolina, working in Durham County, which includes Raleigh-Durham, and Teen Health Mississippi, working in the Mississippi Delta. Following a typical quality improvement process like Plan, Do, Study, Act, the project involved routine data collection on clinic and individual level practices related to adolescent sexual and reproductive health, including confidentiality and parent engagement. Using this data on adolescent healthcare from publicly funded clinics participating in TAC, this analysis sought to characterize parent engagement and confidentiality practices and explore whether implementation of confidentiality practices varies by parent engagement. To do so, we used 3 data sources from TAC, all from baseline data collection. These included a health center organizational assessment completed by health center staff from 11 publicly funded health centers, a provider survey completed by 55 providers working at the partner health centers, and an adolescent patient survey completed by by a convenient sample of 415 adolescent patients at the end of their clinic visit. You can see that the dates of data collection varied based on when health center partners joined the project. This table presents the parent engagement constructs that were assessed, what survey they were included in, and the specific measure and operationalization. Parents as a referral source was measured on the youth survey by the question, how did you hear about this clinic? Adolescents could check all that apply from a list that included friend, parent, adult at school, handout, flyer or poster, website, or social media. Provider support of parent-adolescent communication was measured on both the health center organizational assessment and provider survey. The health center organizational assessment asked, does your health center currently provide educational materials to parents or guardians on how to talk to their children about sex? The provider survey asked about the frequency in the past month with which providers actively encouraged communication between adolescents and their parents about sex and reproductive health. We operationalized responses to this item as never, rarely, sometimes versus often or always, recognizing that it might not always be appropriate to encourage this type of communication. As for the confidentiality measures, the youth survey asked 15 to 17-year-old patients whether they had time alone with the provider, and providers reported on the frequency with which they provided time alone in the context of non-sexual and reproductive health visits. This measure was operationalized as never, rarely, sometimes, often versus always. Communication about confidentiality was assessed via health center organizational assessment, which measured frequency with which the policy was communicated to adolescents verbally or in writing, and frequency with which parents were informed. We combined these measures, creating an indicator of whether both adolescents and their parents were always informed of the confidentiality policy. The youth survey also assessed whether clinic staff told adolescents about the clinic's rules for keeping information private. Our analyses were fairly straightforward in relation to the two objectives. To characterize parent engagement and confidentiality practices, we examined prevalence of each indicator. To explore whether implementation of confidentiality practices varies by parent engagement practices, we examined bivariate associations between parent engagement and confidentiality indicators, drawing on those that were available in each data source. Moving into the results, of the 11 health centers that were included in the analysis, 6 were community health centers and 5 were health departments. Nearly 3/4 of providers surveyed provided sexual and reproductive health services to the majority of their adolescent patients. Of the adolescent respondents, most were female and 15 to 17 years old. This slide presents the prevalence of parent engagement practices. Nearly half of adolescents indicated that they heard about the clinic they attended from a parent, as compared to 26% for friends, the second most prevalent referral source. Most providers indicated that they often or always encourage this communication, and 8 of the 11 health centers provided educational materials to parents, guardians on how to talk to their children about sex. As for confidentiality practices, adolescents reported relatively high levels of implementation, with about 85% of 15 to 17-year-olds indicating they had time alone with a provider at their visit, and 85% of all 15 to 19-year-old respondents indicating that they were told about the clinic's rules for keeping information private. However, a report of confidentiality practices by provider and health center staff was lower, with only about 1/4 of providers indicating that they provided time alone to 15 to 19-year-old patients during non-sexual and reproductive health visits, and only 36.4% of health centers always informing both adolescents and parents about the center's confidentiality policy. The next few slides present bivariate associations examining prevalence of confidentiality practices by parent engagement based on the indicators that were available from each data source. Looking at the youth survey indicators, prevalence of communication about privacy rules and provision of time alone did not vary based on parents as a referral source. Considering health center organizational assessment indicators, there were no significant differences in prevalence of communication about confidentiality by whether educational materials were disseminated to parents, although the prevalence estimates actually suggest that the confidentiality practice was more common in health centers implementing the parent engagement practice. Likewise, based on the provider survey indicators, there were no differences in prevalence of providing time alone by whether providers encouraged parent-adolescent communication. Summarizing findings in relation to our objective to characterize parent engagement and confidentiality practices, we found that parents are a referral source for many adolescent patients. Provider and clinic staff support of parent-adolescent communication is also routine. Implementation of confidentiality practices, however, was suboptimal based on provider and health center staff report. Regarding our second objective, the bivariate findings suggested that implementation of confidentiality practices did not vary by parent engagement practices. Of course, there are some limitations to this analysis. As a secondary analysis, only select parent engagement and confidentiality indicators were available. Practices such as parents helping adolescents get to the clinic or billing practices that maintain confidentiality were not assessed. These findings are not generalizable beyond the health centers participating in TAC, and the findings about the relationship between parent engagement and confidentiality are preliminary and subject to a number of limitations, including that the specific comparisons were limited by the available indicators assessed in each data source, that the data are cross-sectional, that we had a small sample size for the provider and health center samples, and the analyses are unadjusted. Going forward, it will be important to consider the potential benefits of parent engagement and adolescent health services in terms of facilitating adolescent access to care and parent-adolescent communication known to reduce adolescent sexual risk. Of course, it will be important to support parent engagement in a manner that preserves adolescents' rights to confidential care. And there is a need for multi-level research that considers parent behavior in association with clinic-level practices. Finally, in light of the discordance between provider and adolescent report on confidentiality practices and low levels reported by providers, quality improvement initiatives to strengthen confidentiality practices in community health centers may improve delivery of adolescent sexual and reproductive health services. Thank you so much. If you have any questions, please don't hesitate to reach out via email or join with a live Q&A on Wednesday, September 23rd from 3 to 3:30 p.m. as part of the session, Finding What Works, Identifying Ways to Improve Adolescent and Young Adult STI Screening and Care.
Hello all, thank you for tuning into my talk. My name is Maria Zlarzinska and I work at the Rollins School of Public Health at Emory University. Today, I will be presenting results on STI testing among transgender women in the United States, including some pilot data on home-based testing. It is well known that transgender women in the US are disproportionately affected by HIV and sexually transmitted infections. Historically, though, HIV and STI research has grouped trans women with men who have sex with men, or excluded them from studies altogether. Though the behaviors that put trans women at risk of STI acquisition and transmission, such as condomless anal sex, are the same as for cisgender MSM, the context in which trans women engage in risk behaviors is unique. They face unique vulnerabilities, including higher burdens of stigma, economic instability, and mental health morbidity, as compared to cisgender MSM. Thus, trans-focused studies are needed in order to inform trans-competent interventions and clinical care. To address these issues, we launched the TWIST study. TWIST stands for Trans Women's Internet Survey and Testing. And this was launched as an online behavioral surveillance study for trans women. We leveraged online methods for recruitment and data collection, building on our previous work using these modalities for other sexual minority health research. Our objective was to establish TWIST as a system for the ongoing monitoring of biomedical, social, and structural factors that impact the health of trans women. In the pilot phase, which I will be presenting today, we had two aims. First, to recruit and survey 400 participants across the US, and second, to conduct remote biospecimen collection and testing procedures among a subset of these participants. So now to describe our study methods. We collected these data last year in 2019 over the course of about 6 weeks in March and April. Participants were recruited using ads on social media, websites, and apps. Users who clicked on ads were taken directly to an eligibility screener, which could be completed on either a desktop computer or a mobile device. Eligibility criteria included being at least 15 years old, assigned male sex at birth, identifying as a woman or identifying as transfeminine, living in the US, and ever having oral, anal, or vaginal sex. Following the screening and consent, participants immediately completed the survey, which consisted of questions about their demographics, sexual and substance use behaviors, HIV and STI testing and diagnoses, gender affirmation treatment history, mental health, and experiences of stigma and discrimination. No incentives were provided for completing the survey alone. A subset of participants were invited to participate in additional remote biospecimen collection activities. 48 participants consented, and they received a package containing instructions and materials to collect a number of samples, including whole blood, which was tested for syphilis, urine samples, oral and rectal swabs, all of which were tested for chlamydia and gonorrhea, saliva samples which were tested for cortisol, estradiol, and testosterone, and they also received an OraQuick rapid test to self-test for HIV. Participants mailed their samples directly to the Emory Clinical Virology Lab once they were collected, and they received a $50 gift card as an incentive following sample return. For the analyses I'll be presenting today, we restricted the sample to only those who were sexually active in the past year, which included anal, vaginal, or oral sex. We used modified Poisson models to test associations between past year STI testing, which was the outcome, and demographic characteristics as the exposures. These included age, race or ethnicity, and county population density. We collected zip codes from participants and determined their county of residence, then classified these counties according to the National Center for Health Statistics Urban-Rural Classification Scheme. We calculated adjusted prevalence ratios for each exposure. I'll also present some results from the remote biospecimen testing subsample, including rates of sample return by recent STI testing history. Now to the study results. In the sample, the majority of participants were non-Hispanic white, and just over half were under the age of 25. Most participants lived outside of urban counties, representing 44 states and all US Census regions. The self-reported prevalence of HIV positivity was only 1.5%, which is lower than what we would expect for this population. But a large proportion had never been tested for HIV and did not know their status. In the total sample, only 38% reported being tested for any STI in the past year. We saw differences by age, with those aged 15 to 24 reporting a significantly lower prevalence of being tested as compared to older participants. And this is after adjusting for race, ethnicity, and county population density as well. So as compared to older participants, those aged 15 to 24 had a 0.7 decreased prevalence of STI testing in the past year. We also saw lower STI testing prevalence reported by race and ethnicity, but these associations were not significant, most likely due to low sample size of racial and ethnic minorities, which is a limitation of the study. Finally, we observed a significantly lower prevalence of testing among participants living in suburban counties as compared to urban counties. Participants who lived in suburban counties reported only 23% prevalence of testing in the STI testing in the past year. Of the 48 kits that were sent out, 21, or just under half, were returned for testing. No samples tested positive for an STI. Among those who returned results, we saw a lower rate of past year STI testing. Among those who returned STI results, only about a third had tested for an STI in the past year, but among those who did not return STI specimens, almost half, 41%, had tested. This may indicate that remote testing is filling a need for STI testing in a population who would not have been tested otherwise. It should be noted that while self-testing for HIV has been found to be acceptable among transgender women, very little is known about the acceptability of self-collection of STI specimens in this population. We anticipate that formative work, such as in-depth interviews and focus groups as part of future efforts to scale up this project, will allow us to understand and address the barriers to self-collection more fully. In summary, we found low prevalence of recent STI testing in a nationwide sample of sexually active transgender women, especially among adolescents and those residing in suburban counties. It's possible that novel approaches like at-home STI testing may help to increase screening in this population. Our goals for the future with this project is to scale up and better understand some of the barriers to testing in order to improve uptake. This is, of course, extremely relevant in the current pandemic, as it has reinforced the importance of virtual strategies to better understand and serve the needs of transgender women across the US, especially in the context of nationwide HIV and STI prevention service disruptions. Finally, I'd like to thank our participants, my co-authors on this presentation, and our funders. And of course, thanks to you, the audience, for your attention. And I invite you to contact me with any questions or comments by email.
Hello, my name is Austin Jones, and I'm an MD PhD student at Tulane University. Today, it's my pleasure to be presenting our project entitled Evaluating the Adaptation of a Chlamydia Expedited Treatment Program for Young Black Men Using Mixed Methods. I have no disclosures. Chlamydia, or CT, is the leading reportable infection in the United States. Expedited therapy reduces reinfection by providing treatment for a positive test without requiring a medical follow-up. Now, expedited therapy takes a few different forms. First is expedited index therapy, or EIT, and this is given for a patient initially testing positive. There's also expedited partner therapy, or EPT, and this is when the physician provides the medication to the partner directly without having to involve the index. A form of EPT is patient-delivered partner therapy, or PDPT, and this involves the index receiving and delivering the medication to the partner, him or herself. Now, while expedited therapy is a CDC-endorsed and established best practice, there's currently a gap in its effectiveness. Nearly half of partners do not complete EPT. Secondly, expedited therapy research has failed to reach some populations. Expedited therapy has not been well evaluated among men who have sex with women, or MSW, as well as African Americans screened in community venues. So to address this gap, our study objective was twofold. First, using mixed methods, we sought to adapt a novel community-based screening program for young Black men. And second, we looked to evaluate this adapted intervention of CT notification and treatment delivery. We aimed to compare rates of CT treatment pre and post adaptation in our population, which was specifically young chlamydia-positive Black index men and their female sex partners. Now with our methods. Our first study goal was to adapt the delivery of CT treatment. Check It is a seek, test, treat program that screens sexually active Black and African American men ages 15 to 24 for chlamydia at community venues across New Orleans. And Check It's original intervention included the following. First, contact tracing was performed by the State Office of Public Health. Check It provided both EIT and EPT, and delivery of chlamydia medication was done exclusively through pharmacy pickup. We then adapted Check It's intervention, specifically in the following ways. In addition to testing, Check It staff assumed responsibility for notification as well as contact tracing, which were roles previously held by the Office of Public Health. Rather than treating partners with EPT, index men were offered an opportunity to provide their partners with PDPT. And lastly, a mail delivery option was offered in addition to pharmacy pickup. Our second goal was to evaluate the adaptation. And to do this, we conducted a quasi-experimental mixed methods study. We enrolled all Black men who had sex with women ages 15 to 24 who were screened by Check It and found CT mono-infected. In the qualitative component of the study, we conducted semi-structured interviews, 12 in the pre-adaptation phase and 22 post-adaptation. In these interviews, the interviewers explored facilitators and barriers to receiving CT treatment that were reported by our index male participants. In the quantitative component, we then assessed rates of index and partner treatment pre and post adaptation, and we compared outcomes for each step in the treatment cascade, found in the diagram to the right. The first outcome was contacting the index, whereby disclosure results would take place over a phone call. The second was index men making a treatment plan for himself as well as his partner. The third outcome in this cascade was index completing therapy, or EIT. And the fourth and final outcome was the partner completing therapy, or EPT. For index outcomes, we use log binomial models, and for partner outcomes, generalized estimating equations. And this allowed us to account for dependency amongst shared male partners. Now for our results. In our pre-adaptation interviews, we found 3 themes which we used to inform the adaptation of our intervention. In our first theme, we noticed transportation served as a barrier to medication pickup. The second theme we found was that the Office of Public Health, or OPH, was seen as a burden to young Black male participants. The index men felt more comfortable confiding in Check-It staff, who were known and a trusted entity, as Check-It was the ones that initially interacted and tested and enrolled the patients. In theme 3, we noted that the index men preferred PDPT over EPT. The male participants wanted to notify their sex partners themselves and directly. They had concerns about more people, in this case OPH, knowing about their business. They felt that disclosure to their partners would go more smoothly if they were able to offer to PDPT in hand during disclosure. These findings served as the rationale for adding a mailing option, and as well as having Check-It coordinate care delivery, as well as offering PDPT, which were included in our adapted intervention. Here's our table 1 of our index male participants. We had 99 in the original intervention and 85 in the adapted intervention. And both groups were very similar on all measures, other than previous HIV testing, with a higher percentage in our original phase. Otherwise, the 2 groups were very uniform. Here are our outcomes. First, we know 184 chlamydia-positive index men were included. This includes 99 in the pre-adaptation phase and 85 post-adaptation. The first step in care delivery was results disclosure. Again, this was defined as reaching the man on follow-up phone call with chlamydia results and disclosing them. In the pre-adaptation phase, 82% of index men were reached by follow-up phone call and disclosed results, and we increased this to 93% post-adaptation. Treatment outcomes for the index men now follow the left arm of the diagram. The next outcome was the index men making a treatment plan for himself as well as the partners. A treatment plan was made by 81% of male participants pre-adaptation versus 92% of males post-adaptation. The terminus of this left arm is the index treatment completion, or EIT. And EIT was completed by 57% of males pre-adaptation, then increased to 85% of men post-adaptation. In the right arm of this diagram, we have partner outcomes. And 161 women were included in 161 female partners of our index men were found in the pre-adaptation phase, and 153 female partners of our index men were in the post-adaptation phase. So among all partners, 14% of these partners pre-adaptation versus 37% of the partners post-adaptation completed therapy. Now, we also performed a sensitivity analysis, and we included partners of the men who were able to be contacted. And in this sensitivity analysis, we found similar improvement, an increase from 17% to 41% of partners completing therapy. Using log binomial and GEE models, we produced relative risks for each treatment outcome post-adaptation compared to pre-adaptation. All 4 treatment outcomes were found to be statistically significant in improving these outcomes in our adapted treatment delivery system. The adaptation led to a modest yet significant increase in our ability to contact the index with test results, as well as making a treatment plan. We also saw a 45% increase in index males completing therapy, or EIT. And most prominently, we noted that an approximately 3-fold increase in partners completing therapy. This was consistent between our original analysis found here, as well as the sensitivity analysis conducted purely among female partners of those males that were able to be contacted. The study has its limitations. First, it was a non-randomized interventional study. However, we have no reason to believe that there were any differences in our groups that could be associated with these outcomes and therefore confound the relationships seen here. Treatment outcomes were also measured per self-report. Retesting these men was not feasible and would have led to a high loss to follow-up in this hard-to-reach population. And lastly, men were enrolled through a convenient sample. In conclusion, PDPT with the male delivery option increased uptake of both index and partner treatment, compared to a third-party contract tracing approach using expedited index and partner therapy. Mixed methods helped us to identify barriers and facilitators for index and partner treatment and ultimately inform our intervention. And we recommend that similar implementation, evaluation, and adaptation should be considered in community screening programs. I'd like to thank the numerous groups that made the study possible. First, the Check It community, including its participants, numerous community partners, our community advisory board, as well as the research assistants. I would like to also thank our partners at the Louisiana Office of Public Health, of course, our NIH funders, my PhD advisor and study PI, Dr. Patty Kissinger, as well as all of the study authors that helped contribute to this research. Thank you for your time. I look forward to seeing you at the conference, and I would love to welcome any questions you may have. Thank you.